So we are live.
So good evening, everybody, and welcome to this session called as Publish and Flourish. This is jointly being hosted by the Indian Journal of Ophthalmology, headed by Dr. Santosh Honavar, and also by the Karnataka Ophthalmic Society. The aim of this particular webinar is to make it easy for one and all to publish our work, our data, our clinical work. As you all know, I think it's very, very important that we also take forward what we have already done so far and allow it for our peers to take advantage from. We'll start off with the first talk by Dr. Anand Vinekar, and he will be talking about what is the itch, why do you actually need to publish? And I think that's a rather important talk because we do know that we have to publish, but then what is the advantage that it has? And why do we need to do it is what Dr. Anand will be telling us. Dr. Anand currently heads the departments of pediatric retina at Narayan Nethralaya and is best known for his KIDRA program, which he founded and is the director of. Anand's program was the first tele-ROP model in the country and perhaps one of the largest in the world now. The program has completed over 2 lakh sessions in rural areas, and relevant to today's theme is the fact that he is published in all formats and has over 95 publications, 28 chapters, and 1 textbook. His publications have shaped policy and programs across the world, and recently he was named in the Stanford University list of the top 2% scientists in 2020 and named in the top 10 ROP specialists in the world in 2022 by Escapescape based on the impact of his publications over the last decade. So I think he's the perfect person to talk about what is the itch and why we need to publish. Over to you, Anand.
Thank you, Dr. Chaitra, and thank you, Dr. Honavar, sir, for this opportunity. I think it's a wonderful collaboration between IJO and KOS, and I'm really honored to be a faculty on it. So I think the topic's been introduced. So why do we need to publish? Firstly, I'm not an expert in the field, and I'm certainly not trained in the art of the publications compared to some of the other speakers that you'll hear. I'm only sharing some of my experiences, a lot of failures and a few successes, and I think that's the journey that I want to share. So just in terms of reasons, well, it's an amazing feeling to see your name on PubMed when you get your first publication or any publication. When you get that acceptance email, it's something it does to the way you feel and the way you work. But that aside, I think let's look at it from a more scientific basis. Certainly, it improves the way you write. I think the more you decide to publish, you will have to accumulate your thoughts, the knowledge that you have, and you will realize that sometimes what you aim to talk about and the way it is published is not in sync with the way publications run. And I think this is the journey that we'll all need to develop. It helps in knowledge upgradation naturally, because if you have some amount of information that you want to publish, you have to compare it with what's already there and then see whether it's required and how will it see the light of day. This about a decade ago was probably the first prospective study from a rural area, and I'm going to delve into my own examples. And from there, I think the fact that this disease was no longer going to be seen only in the cities, but also in the rural areas started coming out. So that's the knowledge that you can add and, of course, improve on, both for yourself and the society that you work for. It also helps you to understand literature better. And there are going to be talks on how to navigate through PubMed, so I'm not going to go into that. But most importantly, it helps you enhance your field. And that could be the genre of ophthalmology, a subsection, maybe retina or oculoplasty, maybe more niche like tumors, keratoconus, retinopathy or prematurity in my case. So for example, when you look at, the knowledge says that a normal looking macula should also be imaged normally. But in this study that we again showed a few years ago, we found that it looked normal, but it was not subnormal on imaging. And the impact that these findings have on vision in a baby is something that you can actually contribute to the field. It also therefore creates knowledge for others to share and others to use. For example, in this study where we said how babies are getting lost to follow up and how they need to be screened first. Now, this very early screening, which we started in 2015, defied what the national screening program was at that time. But because of the success of this pilot study, which we published, the entire national ROP screening guidelines adopted this new early screening paradigm. So that's how much your small study can actually influence policy. And also gives you peer recognition. And by this, I mean not just in your area of ophthalmology, that's in our area, but in this example, in fields that you might be working together with. In this case, the neonatologists in the pediatric community, because we're talking about ROP. Here we saw how neonatal care can help reduce the severity of ROP and how pediatricians can help improve the follow-up in ROP, both really important because we need to work as a team. And just from pure, okay, so I'm in private practice, I'm not in an academic society. Does that publications help me as well? Yes, it also helps in building up reference. Now, when you publish your work, your peers know that you are in that area, in that field, you have some edge over the others. And in this case, when we, just by publishing how imaging can be a new paradigm shift of screening ROP, the neonatologists all over who probably not heard of you otherwise would call you and reference you, especially if you publish in their journals, which is what this example is all about. It adds value, certainly adds value in terms of improving the science. Now, this is an example of actually crossing your comfort zone. So we are quite comfortable publishing in our own work, but here we were trying to publish in a medical legal field. And this was just looking at all the cases that went against both ophthalmologists and pediatricians in the past decade and seeing how we could learn from that. So just legal aspects of your own condition could be something that will cross the border and help you work with other fields as well. There's no doubt it will give you publicity, but I mean it in an academic sense, not in the sense of putting out a holding. And when you step out of your comfort zone and you start researching on newer advances, then that really gives you the kick of being alive as a researcher. Two examples here where we worked, one on the left is where we work with industry without financial interest. And one on the right is where we were using basic science to help predict the disease. So on one end, trying to create low-cost cameras for this country. On the other hand, trying to assay tears during the first screening itself to predict which of these babies will get the disease. So two spectrums from basic science all the way to taking industry into the field. And of course, it helps in academic growth, especially if you belong to a teaching hospital. In fact, nowadays, the entry level of becoming an assistant professor, sometimes 3 publications, sometimes 5, where you might even have to be the first author or the corresponding author. And of course, subsequent promotions are dependent so heavily on your publication. So academic growth is a no-brainer there. And finally, because it helps you leave your legacy. And, just a small example of what happened just last couple of years back during the pandemic, when the entire classification of ROP was rewritten, and 2 of us from our country were part of the committee, and this is the first time. And we were so happy that images coming out of our babies, our screening protocol, were actually made it to the international classification, and some of the classification itself was rewritten to include the diseases that we see in our setting, not just in India, but other middle-income countries. So that's really the legacy that you can leave behind. So how do we make it happen? Now that we are fairly convinced, I hope, that publication is good, some of the common mistakes that I have made and I keep making and I want to share. So firstly, there is always an inertia. Okay, especially when you take a break for whatever reason. And then maybe this second question we've helped to answer, how will it help me? What can I publish? So the due diligence is really important, as a lot of other speakers are going to cover. But what's really gets you started is a good amount of documentation. So if you document well, then this includes consents, especially even if you're anonymizing the data, it's really important to take the consents, and especially if you're taking special tests. The third mistake is not to run the pre-submission drill. So, look at your methodology, make sure you don't claim more than what you've done. And when you're, don't loosely use words like masked study, because I've reviewed papers where it says mask the group, and on one group that they've done the laser where the scars are seen. On the other end, you've given injections where no scars are seen. So how really have you masked this group? So don't always, anytime, claim more or don't conclude more than your study has actually aimed to look at. Selecting the wrong journal, and I put that in air quotes because we'll never know really what is the right and the wrong journal. But the important thing is to look at the scope of the journal, look where they have previously published, what is the emphasis of that journal, and perhaps if there's no paper in your field in that journal, maybe that's not the right journal. And then you need to decide a niche versus a general journal. So whether you're doing a surgical study, whether it's basic science, if any of you all are involved in animal study, imaging, there are certain journals that pick on certain subtypes. So that's when you might want to do that as well. Ignoring the details for guidelines to authors is something that I've always been lazy to look at. You always think, if you've got the format right, it'll work for every journal. Now that's so wrong because every journal will look at it differently. And the one thing you don't want to do is submit it in a completely wrong guideline. It comes back, sets a wrong tone to both the editors and the reviewers. And so that's not a good start. So it's a good idea to look at these. Language and copy editing, that's where friends come in. Especially be aware of American and British English if you're looking at different journals. Some of these journals even allow professionals to edit it. Of course, there may be a fee, and then there are organizations even in our country which help you do that. The initial enthusiasm is, okay, I've got a bunch of cases, let me publish it. So sometimes we shouldn't publish before the data is ready. Again, it sends the wrong picture, and then we are discouraged with the first few failures that we may have. So for example, a case series. So some journals say, okay, if it's 9 or above, I'll take it as a series. If anything smaller, try to show it as original article 9 or more. Smaller one case series, 1 or 2 just as a case report, and so on. So be aware that these divisions are not always on paper, but they kind of help to know. And if you're doing a pilot, maybe it's a good idea to generalize it, wait for the data to develop and evolve before you publish it. Repeating results in discussion is something that we see very often. So results are what you observe. Discussion is an explanation of what either you've observed, what others have observed, and of course the difference between what you and others have observed. And that's really where the discussion should lie. Many times we see that the results are repeated in the discussion or vice versa, and that's where the problem is. I am hopeless at statistics. I always get it done by my friends and peers. But one thing we are worried about from a statistical point of view is, if I get a negative result, will it not be published? No, certainly it can be, because sometimes the negative results, that is what your intervention did not make an impact, is very important to literature, because other researchers might not go down that path because they've read your publication. So it's not always true that negative results are not going to be published. And it's the twist that you give it when you submit it to the journal that's really important. Now, plagiarism, I'm sure there are going to be talks on this. I won't get there. But the important thing here is, even if you are quoting your own work, your own image from another published article, you have to take permission. So this is an example of taking permission from one Elsevier journal to another Elsevier journal of our own image. So this is really important. And when a paper comes back for revision, or of course, if it's rejected, if it's a revision, or and if you think it's rejected on looser grounds, you need to stand your ground here. So this was one of our rebuttals to a rejection, which then got accepted because the editor felt that, okay, maybe the rejection was too harsh when we explained why our results were what they were. For example, here we were looking at enrollment of a so-called free way of enrolling babies into the government hospital, and the editor said, why is your enrollment so poor? Why is it only 46%? So we had to explain that money is not the only thing that drives enrollment into studies, especially in countries like ours. And when we explained that, and the editor understood that we were not fibbing on our results, but we were actually giving real results, even though they were so-called not encouraging, the paper was accepted despite being rejected originally in the same journal. So sometimes holding your ground and writing to the editor makes a difference. Now, resubmitting to another journal. So you sometimes aim at a so-called higher journal, it comes back and you think, okay, so maybe, and sometimes the editor himself tells you that I think this is better suited for another journal. This is, not a poor loser situation. You actually have the ability to change your journal. In this case, it was rejected by ophthalmology, but it was accepted in IOVS. So it's a good idea. So I'm going to end with a person whom I've been mentored by and someone whom I've really looked up to, and I still do. And just as an example, how you can publish both in width, and of course, we know that he's published so much in depth as well. So this is Professor Amod Gupta, former dean and head of the Advanced Eye Center at PGI. Just taking you through this. And of course, he's known for so many areas of innovation in ophthalmology, but just look at the width here, not the depth, the case report, a case series, a group that we spoke about, a photo essay, a letter, a short communication, a technique or an investigation, original research. Of course, there are many, a review article, which, after you come to a certain point, you've been either invited to write a review or you submit a review yourself. And of course, this is probably at the helm when you're asked to give an editorial or comment on an editorial or a commentary on an editorial. So I think that's a short journey of the mistakes we make and a fine example of where you can, overcome all of that. But most importantly, I hope I've answered the question, why do we need to publish? Thank you so much for this opportunity.
It was wonderful, Anand. Very nice summary of what you've gone through, actually, with live examples of your own work. I think that was very illustrative. Any comments by any of the panelists?
I just had a couple of questions for Anand, actually. Anand, it's been great working with you, and I'm there on several of the work that you've done. But I just wanted you to tell everybody who's here as to, is there any age to start off, literally, when to start publishing? Because you've been in Johns as a postgraduate. When was your first paper? We do have PGs in our institute, and all of us train postgraduates and fellows. So is it too soon to start? When is a good way to start? And do you need a mentor? And, this is something that will inspire others to start off.
Thanks, Chaitra. Obviously, the earlier you start, the better it is, especially if you're in an academic position. But again, it's never too late to start. We've seen people who've been in private practice and then who've made lateral entries into academic institutions and started then and done wonderfully well. Of course, I think if you have a mentor, it is amazing. And as you mentioned, St. John's, I think my first publication was in undergraduation, but had nothing to do with ophthalmology. It was an animal study in pharmacology, and NIMHANS was very close by to St. John's, and it was a sort of joint collaboration. It was a wonderful experience working with rats, but I think that sets the ball rolling. My first publication in ophthalmology was as a junior resident in anterior segment. So I think, no, there is absolutely no age where you can start. And even if you're not lucky enough to have a mentor, we have a lot of peers. And I think we have societies, and we have talking about state societies or the national societies, and there are enough and more number of us who will be willing to help. And you've seen how a lot of them reach out to us. And I think this is something that we can take on at any age and any designation.
Okay, so any other pointers on how you can keep it going? Because, at one point of time, I think everybody reaches a plateau and say, okay, now I'm done with my 50, I'm done with my 100. We all have targets. And once we reach there, I think we tend to become a little lax. So is there anything that keeps one going, something that can push us to do more, so that we don't reach that stage where, we've said we've done enough?
I think that fire in the belly is important, but one should not aim at numbers, I feel. It should be the impact of the work that you make. So it's okay if you have 25 publications, but if you have, they've made a difference to your field, and that's amazing. I remember Professor Gupta saying that if you have 5 publications as first author where original articles which have changed your field, then you're an expert. So you don't really need, I mean, it's amazing to have 500, but I think, and I'm not even the person who should be answering that. There are all of you, including yourself, who've got way more number of publications than me. So you all should actually be telling us how that journey goes on. But I think for me, it is just doing your work, finding something novel and trying to publish it to change the field and make an impact. I think that is enough of the fire to keep you going.
My last question, Anand. Vinod, you want to say something?
No, it's all right. Yeah.
No, go ahead, please.
Make a comment?
Yes, sir, please.
Yes, sir. I always try to impress upon the juniors that is publication is more important. It's the gold standard. It's aged in the history. If you put in the PubMed in your article coming out, there's nothing, nothing can be more pleasant and more valuable than having some presentation of 8 minutes in some society or some state meeting or national meeting. That's important, but more important is the put into the print and get into the PubMed. That's what I want to impress my colleagues and juniors.
I think that's a very important point, sir, that we're leaving our legacy behind, and Anand also mentioned it. And for somebody like Dr. JB or Dr. Honavar or Dr. Anand, who have very niche areas of research, they have a very focused point. I think it becomes a little more focused even to publish the research, as against some of us who don't, have anything specific or a particular field that we are working on. And coincidentally, the rest, all 4 of us are also again from the field of retina. So any pointers or anything like how one who has still not really gone into a focus area can, publish their work? Any pointers from anybody in the panel, how to start off? Maybe even Dr. Honavar can answer that, because you've done so much work on RB that, everybody knows that you're the person to go to. What about the rest who are doing multiple things, who could be even a general ophthalmologist?
I think it's important for everyone to publish, and sooner they start, the better. I would say residency is the best time to start publishing, because they'll be seeing a lot of cases at that time, and that sets them going, and then that improves their curriculum vitae also. Maybe a lot of doors open if you have a better CV than you compare to your peers. Anybody can publish anything that is good. Even a case report is good enough to publish. So starting off is the most important thing.
Great. So thank you. Yeah, Vinod, go ahead, please.
Just a small point. I always feel that a lot of us are doing great clinical work, and we are remembered by clinical work, but most of us tend to be forgotten when the generation gets over, because that is the effect of your clinical work goes away. But something which you put on paper, it is in print, especially in the era of internet today, it's very, very difficult to delete and erase. So it's kind of, your work becomes kind of permanent once you publish it in index journals, I think, and it's very, very important to publish.
Yes, I agree. And thanks again, Anand, for having put that interesting way of telling us why you should go about doing what you have to and how not to do it wrong. I think we do have a lot of talks on how to write a paper, and this was a good take on how we should avoid making those mistakes that can bring us down. So we'll go over to the next talk. This is on literature search and reference management. I think it's very, very important a topic, because it forms the foundation of any paper. It makes it that more easier for us to get the flow into the paper when we have the relevant literature and we know how to manage our references, because most of us tend to try to do it, at the end of it, and that really doesn't work. It makes it more complicated. And to do this talk, we have Dr. Apurva with us. She's a young ophthalmologist. She's a vitro-retina consultant at Joshi Eye Institute, and her interests include retinal imaging and complex VR surgeries. She's already been publishing quite well in her specialty, and she's the IJO Retina section assistant editor, which proves that she knows the job well. And she's also an UC office bearer, which goes with her young ophthalmologist tag. Over to you, Apurva.
Thank you. Can you hear me?
Yes, you're audible.
Right. So thank you so much for having me, Dr. Chaitra and Dr. Santosh. It's an honor to be here. So I'll dive straight into my talk. So literature search is basically to find high quality articles to answer a specific research question, to look at what has already been published, and to have an in-depth review of literature. So there are some techniques of doing this. PubMed uses its own lingo or algorithm. So we'll look at them one by one. The first is to know what are Boolean operators. The next is to know what is nesting. Then we'll talk about truncation. We'll talk about field tags, and we'll talk about filters. So let me give you an example of a research question. Does addition of photodynamic therapy to anti-VEGF treatment regimen reduce the risk of recurrence in polypoidal choroidal vasculopathy? So let's break it down into 4 components. The first component being PCV, second being anti-VEGF, third PDT, and fourth is recurrence. Now, how do we go about searching for this? Let's delve into the first concept of Boolean operators. This includes 3 terms, and, or, not. And these 3 terms must always be capitalized. If we say cats or dogs and the or is in not capitalized, it will be automatically replaced by and by PubMed. So let's look at an example of and. Now, if we type polypoidal choroidal vasculopathy, we get 1,500 results. If we say PCV and anti-VEGF agents, we get about 76 results, which means PubMed is showing papers that have the mention of both PCV and anti-VEGF in the text. So this will show a lot less results. And if you add one more component of PDT, it will show even lesser results. So to sum it up, and Boolean operator basically gets you the articles that includes all the 3 in it. So coming to not. Now, if we say PCV and not anti-VEGF, so it's going to show us articles only of PCV, and in this Venn diagram, it's going to exclude articles that has anti-VEGF as well. So it's going to have only PCV, articles that mention only PCV. Now, or is a very broad search wherein you get a lot more articles, because if we say PCV or anti-VEGF or PDT, it means it's going to find articles that mention any of these. So it's a huge result that you're going to get with thousands of articles. Now, when we talk about synonymous terms, let's look at anti-VEGF treatments, for example. So the thing is, different researchers refer to these as different things. Like maybe some researchers call it anti-VEGF injections, some call it VEGF inhibitors, and some call it angiogenesis inhibitors. The possibilities are endless. So what PubMed does is, or Medline articles basically use a controlled vocabulary. So there is something called mesh terms, which means most of these articles are tagged with 5 to 15 mesh terms, which are specific subject headings. I'll give you an example. Suppose I put anti-VEGF in my search box. I will scroll through my results and find a particular article that suits my search about anti-VEGF. You get these mesh terms at the end of the article. So when I press on one of these and I search in the mesh database, you can see that there is mesh database that comes here. And this is one more mesh term that I have used, and I'm searching that. Now, if I select these mesh terms and add it to my PubMed search builder, it gives me more number of articles because I'm using alternative terminologies that others may be referring to as. So one more thing here is that when we use multi-word phrases, for example, anti-VEGF treatments, or angiogenesis inhibitors, which are two words, we usually put quotes around them to refer to them as one term to be searched for. So that way, VEGF becomes, it starts with a quotation and ends with a quotation after A. And since these are mesh terms that I have added to my search query, it's going to have mesh in square brackets. And one more thing is that this whole thing has to be bracketed with a simple bracket. It's just like algebra, where A plus B plus C means A plus, if you're looking for B or C, it becomes A plus B and in bracket B plus C. So basically it's algebra. So now let's come back to my research question. I had 4 components to my research question. So PCV, I have added this mesh term and I have put this whole thing in bracket and used an OR in between. And this is the second component wherein I have used anti-VEGF or angiogenesis inhibitors, which was a mesh term that I found, or VEGF-A, which is a mesh term that I found. And this whole thing goes in brackets. And PDT or vertiporphin therapeutic use, again, mesh terms that I included in my search. And recurrence, as in recurrent bleed or recurrence mesh term. So this, if I add all of them, this becomes my research query. So as you can see, I have copied this and I'll paste it in my PubMed. And this is the result I get. I get 9 results, which specifically talk about PDT in PCV in addition to anti-VEGF to see the number of recurrences. So this has become a very focused search strategy for my research question. So 9 results is a good number to sift through. And so basically you add in similar terms, place an OR between them, and group the OR terms in brackets, put double quotes around multi-word phrases. So to make it simple, the formula is component number 1 in quotes or its synonym mesh, and the component number 2 or its synonym and so on and so forth. So coming to the concept of truncation, so let's have this research question as an example. So does mobile phone use in children increase risk of myopia? So if I say mobile phones and children and myopia, I get 2 results, right? So when I use truncation, basically what I'm doing is I'm putting an asterisk at the end of phone so that it includes n number of possibilities after the word phone. So phones is one possibility. Child. Now, if I put an asterisk after child, it can be children, it can be childhood, and myopia can be myopic, myopia. So basically, you truncate words and add an asterisk to add any number of possibilities after the said truncated spelling. So now I found some mesh terms for mobile phone, that is smartphone or cell phone, and I've truncated child and myopia. So I've got 33 results. So that's a lot more than 2 article results. So now let's come to filters. Filters is very simple. Basically, you can be more focused in your search. You can go for maybe publications that are 5 years old or lesser. You can go for only meta-analysis. You can go to additional filters and go to say anything, age, sex, journal. You can choose preschool children and 6 to 12-year-old children, and you get only 1 result for that. So you know what has been published in this particular very focused, the focused research question. So another very nifty tool is this field tags. So basically, if you want to use a field tag, you basically TIAB and TW in this example. So this is CSCR and micropulse laser and choroidal thickness. So if I want to look for articles that have micropulse laser in the title and abstract, TIAB, and choroidal thickness in the text, the word choroidal thickness, I put that as a field tag and I get results which are capturing these specific subject headings in the title and abstract and text words respectively. So for example, now I want to see a particular author's work in a particular field. Like I saw that Dr. Chaitra has a lot of articles on COVID. So I say COVID and Jaidev, put that in author, suggesting that Jaidev is the author. I get 17 results, which means she has 17 articles on COVID. So, okay, so one more tool is that you go down in the PubMed page, you'll find clinical queries, and you can enter a search term here, for example, central serous chorioretinopathy, and it will give you 3 columns like this. One is the clinical study categories, in which you can, depending on your research question, whether it's an etiology question or a therapy question or a diagnosis question, you can choose the category. Can choose, systematic reviews appear in the second column, and the third column has medical genetics. So this is a very nice tool in the clinical queries. And yeah, so this is in the genetics column, you have so many things that you can look at. So to summarize, we have Boolean operators and or not. We have grouping of multi-word phrases where you have to use quotation marks for terms that have more than one word. You have to put an or between synonyms, that is mesh terms, and whole bracket them like algebra. For example, laser therapy, notice the simple bracket before laser therapy, or laser photocoagulation in quotes, in bracket mesh, whole bracketed by the simple bracket. And then you truncate. As an example, I've written truncate or truncation. Field tags like author, title, abstract, title, text words, and filters like article type, age, sex, publication year, etc. So I used to find writing references or bibliography very daunting. So one of my friends taught me how to do that using these reference managers. They are really something that all of us should be thorough with, and it's a very good tool for thesis writing. I encourage all my colleagues and friends to learn this and just relax in writing their bibliography. So mainly there are 3. One is EndNote. You can see it has got an exorbitant cost, but it has unlimited storage. There is Mendeley, which is free with a little bit more storage than Zotero, which is also free and has only 300 MB of storage. But for me, Zotero for the win. I use Zotero and I know very little about the others. So I'm going to talk about my usage of Zotero. So nothing, it's just simple. Go to zotero.org, download it. So you have 2 things that you have to download. One is I use a Mac, so Zotero for Mac, and use a Chrome connector for Zotero. I'll quickly tell you what that means. So this is how the Zotero app looks like. This is my library. So my library has got a lot of articles, but in the library, I have subtopics according to what paper I am writing. So these are some of the manuscripts that I have, which have a folder for each one of them. So next, now if I go to say this particular manuscript, then I have all the articles that I have read and saved to Zotero to use in my manuscript. So now how do we use the Chrome connector? Basically, suppose I am reading this article on PubMed. I right click simply and I save to Zotero, and it saves to the particular folder that I am interested in. I want to put this article in. So suppose I'm writing a review article, so that goes in MacTel review folder on my Zotero. Then when it appears in my library like this, now you see, just a second. Yeah. So now if you look at this, there is a section called notes. So I can actually make a note about this article, and this will come right next to the article as a note. And that's so cool actually, because you know what you are interested in this particular article. And then you can actually access the PDF of this article, and you can click on it, read it on Zotero, highlight what you want, so that you have done everything on Zotero, including taking notes and highlighting important points. And then what is the style of referencing or the style of bibliography? So you go to preferences, you go to cite, and these are the styles that are available. You can get additional styles if you don't find your style in the list given. So this is basically something I added. What I use is, I mean, most journals require the Vancouver style of bibliography, the superscript format. So this is how I finally insert a citation and the bibliography. So basically, the Word, once you download Zotero, Word gets an additional tab called Zotero. So you go to Zotero, and wherever you keep your cursor, you want to add a citation, and you find the article that is the reference for that particular sentence, and it simply inserts the number automatically, and here is the bibliography automatically in your list of references. So that's the end of my talk. I think I finished in time. So happy writing to everyone.
Thank you, Apurva. Very well done. And I like the way that you've explained it in a very practical way. You've made, I'm sure you've taken a lot of trouble because you've done small videos to show it rather than just do it on text, because that makes it very difficult for one to comprehend. So each and every step, whether it was a literature search or whether it is, in inserting the references. And I agree with you, the reference manager tool is amazing. I remember before I had access to any of them, you had to copy paste, I had to keep 2 Word documents. It was so confusing. And somewhere along the way, we would forget the numbers and then we'd go back and say, oh no, I missed one. So this is automatic and it really is very, very helpful. So I very well explained about Zotero. And I think since that's freely available and you've explained it very well, that's the way to go. As far as literature search goes, I think a lot of people think that it will just be an access to free text or full text. So that's really not what literature search is about. It's about a lot of other things, and PubMed is just the library. PubMed doesn't give you, full text. That's unfortunately, at least at the beginning, most people don't tend to realize. So would you be able to add a couple of pointers on where the sources are, for full text? When you don't have free, what are the other ways that one can use, to access full text?
So the most legal way is, of course, asking your institution to subscribe to journals and use the institutional access to journals. Paying like $100 to view it once or even download it and view it is not practical for a lot of us, especially residents. I'll take this opportunity to say that it's really unfair of the publishing industry to have such a high fee for viewing their articles. It's almost prohibitive. It's like only people who can pay can view articles. That defeats the purpose of publication, where you want more people to view your publication and get help from it. So I don't mind saying that Alexandra is an inspiration. She has, spearheaded free research and free for all access to hundreds and thousands of papers on Sci-Hub. So arrest me, but I go to Sci-Hub and get my articles for free. So that there is a problem with that. I think post 2020 Jan, there are no full texts there either. As long as she is in this legal soup, I think it's going to take time for us to access full text. I would love to hear. I have a couple of friends at PGI who help me out with some journals. They do give me full text. And one more very effective way is to join ResearchGate and ask the authors themselves to share their full text. And you can, another very good way is email the researcher directly and ask for a full text, and they'll be very happy to share with you more often than not. So these are some ways of getting full texts.
Dr. Honavar had a few, sir, if you could just mention them, because I don't know whether all have access to the chat.
So I think she mentioned everything. Purva mentioned everything. I just have to add that if you're a member of AIOS, then you have access to ONE network, which provides a bunch of ophthalmic journals and the archives as well. So that is actually very useful because you get most of the important journals there. Rest of it, of course, you can go on a Sci-Hub, which is extremely good, and it's not illegal, so to say. Well, of course, it's paralegal maybe, but everybody uses it.
Yes.
Writing to authors actually may take time. They will respond. Most of the authors do respond. It may take a week or so for you to get it.
And another, yes, Sunny.
Yes, I just wanted to add that the One Network or the ONE network by the AIO has most of the journals that most of us would be citing, and those mainly have journals which are published by Elsevier. Now, the other large group of journals which is published by Wolters Kluwer is under the Ovid category. So that is available from a website called iPlanet, which is run actually by Sun Pharma. So you can get in touch with Sun Pharma representatives, and so all the subspecialty journals, so cornea, retina cases, brief reports, Orbit, all of those are under Wolters Kluwer and Ovid, and that is available free of cost through iPlanet, which is run by Sun Pharma.
You can actually become a member of iPlanet. You can simply have to log in. It's a free access website, and you get a bunch of journals there as well. And DOS library also supplies references.
So I think some of us in institutes also have licenses to access articles, and we're always open to help. A couple of us who finished courses or PhDs from other institutes, those institutes also as alumni allow us access for most journals. I don't think there is any one source that gives you access to all, and there are particular journals, I think JRS, for example, and OSLI, which is impossible to get. It's just so difficult to get full text of these journals. And I agree with Apurva. I don't think it's fair. If you're publishing for your peers to know, and it's going to be so expensive for us to read, really what's the point there? But I think journals have to run their journals. They have costs involved. They have, and Dr. Honavar will agree. So it's not really easy. And I think they want to keep some exclusivity. I guess that's probably some of the reasons. I think one of the attendees has raised their hand, Dr. Arvind, but I don't know whether they can ask a question except on chat.
I think we have one more way. Most of us have friends in US, and they have very good libraries, and they have very good access, and most of the journals and articles are at direct access. So if your friend is kind enough, if they can share the password, well and good. Otherwise, you can always request your friends there.
I do that often.
Yes, me too. Especially for OSLI and JRS, that's the only. Tech team, if you can ask Dr. Arvind to let us know what question he had, because we'll need to let Dr. Apurva go. She's got another commitment now. So if no other questions for Dr. Apurva, thank you so much. Very well done. I don't know why you said why I'm here. You did an extremely good job. Thanks again for all the effort that you put into even making the presentation.
Thank you, ma'am. Thank you so much for having me. Thank you.
So we'll go to our next speaker, Dr. Sabyasachi Gupta. He'll be talking to us on the types of studies. I think that's an extremely important talk, because most of us don't understand the difference between each one of them, how to approach the study, and how to eventually bring it into a publication format. While Sunny brings up his slides, let me do a quick introduction. He's a vitreoretinal surgeon practicing at Future Vision Eye Care, Mumbai. He's currently the associate editor of Indian Journal of Ophthalmology. So he has a lot of experience. I think even before he came into IJOs, that, how to go about the publishing so-called skill. He's done his diploma in ophthalmology from JIPMO and DNB from Arvind Pondicherry. He's a research clinical fellowship in VR from Shankar Nethralaya, and another fellowship from Wilmer Eye Institute, Johns Hopkins, US. He was awarded the McCartney Prize by the Royal College of Ophthalmologists in London 2010, the first ever non-British national to receive this award. and also the G. Venkateswamy Gold Medal in DNB Ophthalmology in 2009. He headed the research at Arvind Pondicherry from 14 to 2016, and he has 100 plus papers in index peer-reviewed journals. He's the founder of the Sen Gupta Research Academy, one of its kind portal offering e-learning lectures on research methodology and service for manuscript preparation. But today we'll have a live lecture by Sunny on the different types of studies. Over to you, Sunny.
Thank you so much, Chaitra. I hope I'm audible to all of you. So very good evening, and thank you so much to Santosh sir and Chaitra for giving me this opportunity. And so I am usually called to speak on biostatistics, and but so this is a slight change for me, and I hope I'll be able to do justice to this topic. So today we are really talking about different types of studies, and why this is important is because if you make the wrong choice, this cannot be reversed, isn't it? So we've already heard very enlightening talks by Dr. Anand and Dr. Apurva. So these were all before actually you start the study. But now that you have a concept in mind, you have the know-how, how you want to do it. The first step is actually to think about what is the type of study you want to do. So we need to know what are the different types of studies and how you will choose the one which suits your study question the best. Right. So, so there is a lot of confusion around this in terms of, there are many different classifications, and there are terminologies like prospective versus retrospective. There are terminologies like randomized versus non-randomized, and somewhere or the other, it's all jumbled up, and then people, especially residents, find it quite hard to understand, what is the best way and what is the right type of study for your paper, isn't it, or for your study. That is really the holy grail, and to understand that, you need to understand a little bit about each of these study designs. So that is what we're actually going to take a look at today. So overall, you can classify studies mainly into two types. One is a descriptive kind of studies, and the other are analytic studies. Under descriptive, you have two major headings again. One are surveys, and other are qualitative studies, which are questionnaire based. And in analytic studies, you have again two types, but one is experimental and the other is observational. And so under experimental, you have randomized parallel group and randomized crossover studies, and in observational, you have cohort, case control, and cross-sectional studies, right? So this is a quick overview of what this is. You will notice that the word prospective and retrospective have not at all appeared in this study design, isn't it? So that is where all of this sort of confusion arises. So we'll take a look at where all of this fits in. So the first kind of the study that we look at is different surveys. These are generally population based or community based studies, where the researcher actually goes to the the site. It is not done within the hospital, and generally involves very large samples. And what surveys most of the time are doing are looking at prevalence and incidence of disease. And surveys which slightly smaller scale are, for example, are CAP or knowledge attitude pattern of a particular disease. Say, there are a lot of CAP surveys on diabetic retinopathy and how patients, what are the knowledge, attitude, and patterns of patients with diabetes about diabetic retinopathy. Different studies on uptake of various different modalities, like, for example, spectacle usage, cost effectiveness, and others. So these are examples of some surveys. The other kind of descriptive studies are qualitative. Surveys are questionnaires. And so questionnaire development is a whole kind of different entity on its own, and most of us are not really getting into a lot of details. We use pre-existing questionnaires, and don't develop questionnaires. But so there are many questionnaires. So commonly ones used are the NIH or NEI VFQ, or that is a visual visual field quality of life questionnaire. There is an Indian VFQ as well. Now, the many steps involved, such as initially we use a pilot questionnaire, then we use open-ended questions. We don't give them options. So you use a interest group and give them open-ended questions, so they will just answer the question as they like or as they think. Then you sort of have themes, and then you use close-ended questions, where then you close-ended means a question will have, say, 3 or 4 options. That's like a multiple choice. Then you go ahead and do a field testing for reliability and validity. You do a test and retest. So there's a lot of different parameters involved in overall in questionnaire development or qualitative surveys. And finally, you narrow down to a final version, right? So Descriptive surveys generally fall under the gamuts of surveys and qualitative studies. Most of us are not directly involved unless we are in the field of epidemiology or doing qualitative studies. But these are examples of descriptive studies. The other larger group, and the one that we are most of the times involved, are experimental and observational. So experimental, under that we have randomized controlled trials, and in observational we have cohort, case control, and cross-sectional studies. So all of these analytic studies can be organized in the form of a pyramid, which is called the hierarchy of study designs, where these are different levels of scientific evidence which are produced, where at the bottom there are animal and laboratory studies. Then you have case reports or case series. Sometimes editorials, point counterpoints are also in that gamut. Then slightly higher levels of evidence are generated by case control studies, which are usually retrospective. Then you have cohort studies, which are on top of that, which produce better levels of evidence. These are examples. These are generally fall under the gamut of prospective studies. Then you have randomized controlled trials, which are which generate even higher levels of evidence. And then you have meta-analyses and systematic reviews, and finally clinical practice guidelines. So overall, we need to understand that the lower the sort of type of study in this pyramid, the lesser the level of evidence that you're going to create. But if you're going to think about doing your studies, what you need to do is you need to graduate slowly from form case reports, and then you should think about you should write case reports initially, then perhaps go and do some retrospective studies, then probably graduate on to do better prospective studies, and then maybe design randomized trials, and at the end think about writing meta-analysis and systematic reviews. It sort of sounds very easy to put all literature together and sort of write a review, but remember then that becomes a narrative review and not a systematic review. And meta-analysis is a very large kind of subject which we don't have enough time to get into, but it's not a great idea to start writing reviews straight off. So levels of rejections are also going to be high, and you probably are not going to do a great job. So it's best to start writing with case reports, then graduate on to larger studies, and then do perspectives. And if you have a chance to think about doing randomized control trials. Now, what are prospective and what are retrospective? So prospective, the word really means in prospect, right? That is, the outcome has yet to happen. So if you look here, the outcome has not yet happened, but what is happening is patient is exposed to risk, right? So what you're doing is enrolling non-disease subjects. Say, for example, you have diabetics, right? And then nobody has developed diabetic retinopathy. So you are going to enroll non-disease subjects. That is, they don't have retinopathy as yet. You collect their baseline data. You follow up these patients over a period of time, whatever that may be, and then see how many developed disease and how many didn't develop disease at the end of that follow-up. And then you can compare incidence over time and analyze the differences. So why did one group develop disease and why did one group not develop disease? Another common or generic example is about smoking and lung cancer. So where there is exposure to risk, that is, these are smokers, and then some will develop lung cancer and some will not develop lung cancer. So you can actually try and compare and see what led that one group to develop disease and the other to not develop disease, right? So the sort of take-home message from prospective is, as the word suggests, the risk has started, but the outcome has not yet happened. Retrospective, on the other hand, is where retrospective, you're looking back. So the outcome has already happened, right? And what you're trying to look at is you're looking at risk and exposure to risk, and then how many had exposure to risk and how many didn't. So here you have patients with disease and no disease, and then you're collecting their baseline data, and then you're seeing exposure to risk and not exposure to risk, and then you're comparing to analyze differences. So what you're likely doing is identifying risk factors for disease, right? So the outcome has already happened. You're looking back and seeing what are the risk factors for that disease to happen, right? So whenever you're trying to study risk factors, it is generally a good idea to look at, try and do retrospective studies. So this is another study, just another sort of slide to just show you differences between prospective and retrospective in the same slide. So where in the prospective you enroll non-disease subjects, collect baseline exposure data, and then you follow up patients for a period of time, and you compare incidence over time, right? In retrospective, the the outcome has already happened. So you identify a cohort retrospectively. Say for example, tire manufacturing workers versus desk employees. So these are, say for India, you can talk about farmers and who do physical activity, and people who do desk jobs, and then, look at subsequently happen to them, and then you can sort of compare incidences over time as well. But most importantly, whether these are going to lead to any disease or not. So those risk factors can be determined. Now, looking at randomized clinical trials, the main concepts under RCTs are the three words in red that are given here. One is randomization, other is allocation, and third is masking. Right? Before we come to that, we need to understand why randomization is important, and it is purely because of to avoid bias, right? So you don't want to influence studies outcomes by allocating, or if you feel most commonly investigator bias comes in, where you feel that this drug is probably better in this group of patients, so I will sort of allocate one group to a patient with this kind of disease and another group of patients with a different kind of characteristics to the different drug, and then overall the outcomes will be that one is better than the other. But then that all happened because you actually put some patients in that one drug group and some other patients in the other group, right? So that should not happen. So that's where the concept of randomization comes in. So examples are lucky draw or computer generated allocation codes, which are nowadays used. So what we're trying to do is allocate patients by chance. So if there are two drugs which a patient could get, there they could get any one of the two, and that is just by chance. Allocation means who gets what, and there is parallel versus crossover design. I'll show you in the next slide. And then concept of masking is really important. We don't use the word blinding in ophthalmology. So the concept of masking is important, where it could be single mask, it could be double mask, it could sometimes be triple masked, where patient is masked, or physician and patient both are masked, and triple blind is and there are some, other people like an optometrist or things like that, they can also be masked. So masking is very important, and that goes throughout the study, right? So sometimes you may not be randomizing, but you can still bring in the concept of masking in a particular study. So these are the three things which are important. So this is a quick this is a quick video that will show you overall when there are patients which are available. So this is a roll of dice, and some patients go in drug A and some patients go in drug B. However, if there is a physician involved in the center and he says, okay, you three go here and you three go there, that is not allowed, right? That is now bringing in the concept of bias. So that is what is not allowed. And parallel assignment means parallel assignment means at the same time patients are getting into drug A and drug B. So that is generally what is happening. And crossover assignment means some in drug A are then going into drug B, and then who are in drug B are actually now getting drug A. Sometimes it happens we are not sure which drug is better than the other. So this crossover study designs can also be there, though they are not very common. So this is where we started off, where we looked at where we looked at surveys and qualitative studies. In experimental, we now have looked at randomized and parallel group and randomized crossover studies. Now we look at some of these remaining ones, observational studies, which are cohort, case control, and cross-sectional. What we have already actually looked at is cohort studies. So cohort studies where we take people who are exposed and non-exposed and then follow them up over time and then see how many actually got disease. Right. So this would actually sound to you like prospective studies, right? So cohort studies most of the time are prospective studies, and case control studies, again, you have diseased and non-diseased, and you're looking back and you're trying to compare exposure or risk factors. So retrospective studies are generally cross case control studies. So in very simple terms, cohort studies are usually prospective and observational studies, while case control studies are usually retrospective with a control group. Now how do you actually design your study? Now that we know that these are the different kinds of studies, we know that the randomized study is a randomized control trial is something that would bring out the best results, but then sometimes it's very difficult to carry out some studies like that. So you can use the PICO approach to study design, where P stands for participants, I for intervention, C for comparison group, and O for outcome measures. So this quickly tells you what these are. So when you're thinking about your study, first thing you need to think about is who are the participants in your study. And so in general, think about inclusion and exclusion criteria, and will be different for prospective and retrospective studies, right? So P also stands for the problem that you're solving. right? So P is for generally for participants, I is then for the intervention. This is the intervention that you are actually studying. This really means the exposure. This does not always mean surgery, though that word intervention brings surgery or some medicine into your mind. It could simply be a questionnaire that you're using. So what is the tool that you're actually using to gather data is the intervention. And C stands for a comparison group. So this is it's relatively simple to understand. The key question is, does your study need a comparison group? Right? So this cannot be recruited later, isn't it? So you need to think about it even before you're starting. It can be an active or a passive comparison. We've heard about terms like placebo. So these are when you're looking at randomized controlled trials, but comparison groups can also be there in routine prospective as well as retrospective studies. Then O stands for outcome measures, where you define your outcome measure very well. So remember that most studies will study one primary outcome, and you can study some other outcomes which may coexist or happen, but define that primary outcome measure well. And then think about the type of study, right? So you need to think whether you can do a prospective versus retrospective study. Generally, this depends upon how many patients you are getting and how follow-ups are going to happen and whether you have enough time. Then think about whether randomization and masking would make a difference. Not necessarily always that you have to randomize, but masking can always be done. What is the sample size overall required? What are your limitations? Can the study be done in your setting in a time in the time that you have and at a reasonable cost? So the PICOT approach really will help you choose the type of study which will answer the study question the best. While writing manuscripts, remember, we are going to hear a lot about this in the talks coming up, but original articles are written in an IMRAD format where I stands for introduction, M stands for methods, R stands for results, and D stands for discussion. So have these slightly in mind as well. When you're even choosing your study, remember that if you have to discuss your studies with all other retrospective studies and yours is also a retrospective study, it may not have a lot of chance. But if yours is a prospective and most others are retrospective, then that could actually make a difference. Case reports generally are single standalone cases. Series typically are they are less than 5. There are so many others like ophthalmic images, photo essays, letter to editors, consensus guidelines, and Dr. Anand has also shown us some of these examples. So remember that these all sort of bring out different levels of evidence. So take-home messages is consider that pyramid for generating levels of evidence. Always choose randomized trials first. If not possible, then think about doing a prospective cohort study. And lastly, if absolutely not possible, then a retrospective case control study is also all right. Then remember the PICO or the PICOT approach, and funding, feasibility, rarity of disease, completeness of medical records, etc., also play a role in choosing the study design. So all in all, this is how we would look at types of studies. So thank you so much. If you have any questions, I'm happy to answer them.
Thanks, Sunny. Very extensive. I think you have simplified it for most of us, but I think many will still have doubts because it's not really easy to comprehend it, in such a short period of time. So do you have any material available on your portal that can help one, kind of understand it a little better in a slower pace sort of a thing?
Yeah. So, my Facebook page, that is Sengupta's Research Academy, has a lot of material and a lot of links to my blogs, and I have written 2-3 different blogs on types of studies and others. So I'm happy for people to take a look at that Facebook page.
And Sunny, as he's known to a lot of us, also conducts workshops on how to do simple statistics. And he's also done a couple of talks for us. I think that's again a very, very important thing, and it would have been too much for us to cover in these 2 hours. So that is something else that one should really look at. He has some recorded lectures and some on YouTube as well, and he also conducts sessions on that. I think one should explore that option because invariably we're dependent on others to do stats for us. So at least if we can do it for the smaller studies, the larger ones, maybe we still need professional help. But, for our sample sizes of 100, 200, 300, I think that should suffice, because otherwise we're, really tight because we're asking someone else to do it and we don't understand stats. I remember when Anand and I used to take help and people used to send us stats. We used to reply back saying, send it in English. not in a language that's foreign to us. So that's how it is. It's very foreign to us. We don't understand what a particular test means, why it's more important. So besides the types of studies, I think the statistical tests are also very important. Anybody else would like to ask Sunny anything more on this? Sir, anything? Dr. JB?
Oh, I do studies which is not a retrospective, not a prospective. So I have got a kind of a pro forma in my mind or written it up. And when the cases comes, I do that particular group of tests and that particular group of results, particular type of the results, right? And then do a retrospective study. But the design is made previously and follow the design that way. Prospective study is a very time-taking, needs personnel and the funding. The rarity of the disease also often makes it difficult to do the prospective study. So midway, I try to do it. Like a standardized protocol I maintain for my retrospective studies also.
Great. Thank you, sir. And thanks, Annie. I think we'll go to our next topic. It's on the power of a case report. And I think, also important is that IJO itself has started a journal now, a sister concern for the, parent journal, where we're looking at only case reports. So I think it's a very good opportunity to publish. And Vinod will be telling us more on how important it is to publish case reports and how it can actually be a starting point for us to start off on a publication journey, because it's a brief thing that we can write probably in a couple of hours if we put our heart and mind to it. And while Vinod pulls up his slides, a quick introduction. He's the additional professor for VR services at RP Center in AIIMS. He has over 200 PubMed publications, so he's the right person to tell us on how to go about starting with the case report, which could be a stepping stone. Over to you, Vinod.
Just a second, Chitra. I think, I hope. Is it coming?
Mm-hmm.
Yes.
Yeah. Okay. Am I audible?
Right.
Yes.
Yeah. Thank you so much, Chaitra, for having me here. And thank you, Dr. Santosh sir, for having me here. So I'll be speaking about power of a case report. I'll be predominantly first speaking about what a case report can really do. In the second part, I'll be talking about what are the advantages of a case report. And in the third part, I'll be sharing some of my own experiences with the case reports, how you can go about in our routine practice day to day to include and to choose the cases and then go on to publish them. So just a word about this mood is definitely changing. And earlier we used to talk about publish and perish. And now the mood has turned positive. Most of us do talk about publish and flourish. But I think we have one more step to go forward, and where we would be publishing with passion. And I think that is very important because it is our duty, because others have shared their experiences with us. As a clinician, it's our duty to share our experiences with the others so that the medical field progresses as a whole. Now, why case report? Typically, case reports are falling out of disputes, and many reputed journals have stopped publishing case reports. This is because they are typically placed at the foothills of the hierarchy, as Dr. Sunny showed, and they may present anecdotal evidence. And since they receive fewer citations, in fact, many people believe that this is something which is below their level. But I'll try to make certain observations. So this is a small, local journal somewhere in US. And 1981, they reported 5 cases of a pneumocystic carni pneumonia in 5 young patients who were all homosexuals. And later, the same journal reported a case report about the Kaposi sarcoma happening in the similar subset of patients. And in 1982, this condition was defined as gear-related immunodeficiency. And later, it was identified that it was happening in patients who were in the 4H club where these conditions were present. And we all know in later part of the 1982-83, it was known as AIDS. And by now, we know that more than 70 million people all over the world have been infected, and of which around 35 million have died. So this is another case report in 2008, a very small kind of correspondence where the authors reported successful resolution of infantile hemangioma with the help of propranolol. And over the last decade or so, propranolol has emerged as the main first-line therapy of this particular condition. Our colleagues from PGI first reported this wandering Ozurdex implant, whereby in aphakic patients, this implant wandered into the anterior segment. And later, this particular thing was included in the drug insert as a caution. So what I wanted to say is that very small discoveries can go on to become very large things, which can change our practice forever. So that is the power of a case report. The second part of my presentation is what are the advantages of a case report. So first and foremost, the hallmark of any publication is that they include something novelty. And case report is unique in that in a way, even a small novelty which can happen in a particular case can be reported. It has happened to all of us that we have read a case report and then we realized, oh, similar thing has been seen by me also. And that way it sensitizes more readers to report their similar cases and helps in building up the literature. Thalidomide tragedy, which was first reported as letter to data in Lancet way back, was so many cases were reported later that thalidomide was banned. So case reports act as a very important meaning of pharmacovigilance. Chance discoveries can be made with the help of a case report. Lithium is one such example, which is now widely used in manic depressive disorders. Case reports are very useful in rare disorders because all kind of, prospective and retrospective trials are not easy to do with the in rare disorders. Case reports and series form a very important means of building up literature in such diseases. Since most of the case reports describe the disease in retrospect, there are no ethical issues, and natural course of the disease is such that many untoward incidents happen, which make us report those cases, and that is how we again build the literature. Many of us have seen that nowadays a lot of conferences are being held where there are separate sessions for the cases. Now that is very useful because many of us learn our get our clinical experience from those unusual cases. And the reason is because case reports present day-to-day practice and scenarios, and many top journals, for example, even NEJM, as well as ophthalmic journals like Archives, have regular section for educational case reports. Some of the very practical advantages of a case report involve that we do not need large amount of funds for planning a case report. The publications usually happen very fast, as Dr. Chaitra mentioned. If we give 2 to 4 hours to a particular case report, it can be ready in such a short period of time. Nowadays, we have a very flexible structure for the case reports. Many journals allow images in ophthalmology, letter to editor, correspondence, pictures and perspectives, or even photo essays. So all our unusual pictures can be published in the form of case report with very small text in the form of all these manuscripts. Sometimes case reports can even change the way we practice clinically. Now, this is a very interesting story which happened in the First World War, whereby some of the soldiers were being considered as cowardice, or they were malingering, but later they were found to have a psychiatric disorder called shell shock syndrome, and it changed the way we had outlook towards these soldiers. And last but not the least, it serves as a platform for gearing up the youngsters. As Dr. Sani mentioned, it's not easy to write meta-analysis or review straight by. You have to go through a proper ladder. And I think the case reports are the stepping stone towards your publication career. So in nutshell, case reports form the oldest forms of the medical reporting, and we have all read in journals whereby personal communications people cite. They serve as primers leading to new discoveries. As I've just mentioned, they are a very important part of pharmacovigilance, and most of the drugs side effects are reported first as case reports. And as I said, they work as a platform for training in scientific writing and critical thinking. So I would say, rather than the lowest level of evidence, they are the first line of evidence in our medical writing. Now, writing a case report is relatively easy. It has usually 3 parts. Introduction, where we give about the background about the case to be reported and how it adds to the present literature. Then we describe the case report in the detail, and in the discussion, we discuss about the relevance of the present report and review the literature. Now, these are the various functions of a case report I have listed. Whenever you see something unusual, which may be in the form of new symptoms or signs, new associations, or something new happens in the management of a particular case, then that case is worthy of publishing. Now, remember, for publishing a case report, documentation is must at the baseline. And it is very important that patient should be traceable at all points. And for that, we need to make a very good rapport with the patient. And of course, literature search is always important. Coming to my own few example, this is one of my earliest publication in IJO. I was a senior resident, and we had gone to medicine ward to see a patient with dengue fever who was admitted there. And this patient had bilateral periorbital ecchymosis. And at that time, I had this my prized possession and no other thing. So I clicked this photograph with this particular phone, and it could be published later in the form of a case report in IJO. At the same time, this was a very preliminary gadget. You can use sophisticated gadgets like Optos to document the peripheral lesions which never have been documented, and you can publish again with the help of the newer gadgets. So there are again diseases which are beautiful to look at, and once you have got the beautiful pictures, for example, benign fleck retina here, you can publish them as images, and all you need to do is just crop these images, put them together, put some text about the condition, and it is very easy to publish these reports. Now remember, documentation is the backbone of publishing, and never hesitate to document. So all you would lose is some hard space on the hard disk, which you can always later on erase. Now again, a small story here. I was doing a diabetic vitrectomy, and at the end of the surgery, after completion of laser, I was indenting. I could see some cyst, and all I did was took a still of this photograph, and this pars plana cyst could be published as a ophthalmic images. Again, it is important to document timely and smartly. So if you document timely, if you see the picture on your left is more likely to be published than the picture on your right. So it is very, very important to document smartly. Again, a very interesting story. This patient came to me when I was a senior resident, and very, very unusual nodular keratopathy. And later on, when we worked up this patient, we found that this patient had a contact lens, which was put 3 years back and had never been removed. And had I not taken the picture at the baseline, this patient would never have been published. So again, I'm telling you the importance of documenting the cases smartly and timely. So follow-up of the cases is a very useful mean for publication or finding the cases for publication. Inherent vast nature of the medicine makes our work relatively easy, because no two cases behave similarly in long run, and any change in the outcome is an opportunity for publication. So have a look at this case. For example, this is a patient with IRWAN, a little unusual disorder, But when we treated this patient, to our surprise, all the aneurysms vanished in this particular patient, and we could combine this with the review of literature of similar cases in the literature, and we could publish it. All of us hesitate to report our complications, but remember, complications are the one which are the easiest to accept by the journals, and they are the most cited also. So please do not hesitate to report the complications, and they are very easy to publish. Again, do not give up. So this is a patient I saw in my residency, and all I could notice was there was a large vessel which was going through the fovea. Now I didn't know what it was at that time. So I just kept on searching the literature, and once I came across the diagnosis, which was nothing but congenital retinal macrovessel. We have seen several of them. In fact, if you go on PubMed, there are around 50 cases of them, congenital retinal macrovessel, which have been reported. And you will be surprised to know around 10% of the publication on this particular topic are from our group, and we have seen a large number of such patients. All you need to do sometimes is think out of box. This is a common condition all of us see, myelinated nerve fibers. All we did was collected the cases we had seen, put them as a collage, and it could be published on the cover of a journal. You have to be brave at times. This is a patient who had a macular hole who was sitting on top of a choroidal hemangioma, and several surgeons had denied this surgery. But this patient, when he came to me, I went on to operate this patient. This patient did well, and we could publish this case. Another similar case, the patient had a macular hole along with a subretinal bleed. And the usual course would be to put gas and then do a macular hole surgery. We went ahead, did a single stage surgery of extracting this macular blood and closing the hole by doing ILM peeling. And again, because it was a differently done procedure, we could report. At times, you will be simply lucky to have a disease which has never been reported from your country. For example, this particular dystrophy, which has never been reported from Indian subcontinent, we found this and we could report it in one of the top journals. Or at times you will come across conditions where are rare associations. So for example, this particular patient with lipemia retinalis, when we worked up this patient, it had an association with primary chylomicronemia syndrome, and we could report in the Lancet. So to summarize, case reports are the beginning to a new discovery, and we must all report everything that is weird and wonderful. Remember, good documentation is must for any case report, and at times we have to think out of the box. The very fact that the journals like American Journal of Ophthalmology and even now IJO has started a separate journal of case report do signify that the case reports are very important of a part of the medical literature, and we must all report them whenever we find something unusual. Thank you very much.
Thanks, Vinod. It was a crash course on everything to do with case reports. So thank you so much, right from the importance on how to go about publishing and which journals you can publish. But like IJO and IJO have started a separate journal for case reports. There are several journals that do not take case reports at all, or they charge horrendously to publish case reports. I was just wondering if Dr. Honawar can just explain to people why that happens. And what they should do ideally to look for another suitable place to publish it. Of course, right now case reports of IJO is yet to get indexed, but I think that will happen quite soon, given the number of articles that are getting published and the timelines. But why is it that journals don't like case reports, and what is the thing? And the second question to Vinod after that would be if you can add a little bit more on case series. Now we spoke about case reports and how different is case series. Either of y'all can take that question.
Journals don't want to publish case reports mainly because of the reason that it takes a lot of pages, number one. It's expensive to publish case reports, and the dividend that the journals get out of case reports is minimal because they're not cited often. And more importantly, it brings down the impact factor of the journal, because case reports, whenever there is an abstract and a body, that is description of the case, discussion and conclusion, under those headings, or even without it, if those components are part of any report for that matter, even if it is disguised as a letter to the editor, is considered a citable item. So obviously journals have a lower impact factor if they accept case reports. And that is one of the reasons most of the journals, although they want to publish case reports, they hive it off to another sister journal, so that their main journal does not get hit because of increasing number. And we also had to do that for two reasons. One is that we started getting too many submissions which were case reports, and we were unable to accommodate all that, even though they were good in the main journal. And the second was that since we had too many case reports, our impact factor would have gone lower. So that is one more reason why we had to hive it off to a sister journal. But that will ultimately get indexed. IJO case reports took time, took 2 years, but it's now indexed. Similarly, IJO case reports, since we are following all the rules of the game, should get indexed in the next 18 to 24 months, in a tenure of the next editor at least.
So does the impact factor of these case report journals lesser, because IJO might now already have an impact factor, and you were saying because they don't get cited also, is the impact factor much lesser?
Yes, it is bound to be lesser. Yes, it is bound to be lesser. Well, of course, it can hover around 1.5 over a period of time, but initially it's bound to be less.
A lot of them now have paid options, like BMJ, for example, charge quite a bit for case reports. But unfortunately, we have to resort to some of these because there is no other way otherwise to publish them. And some of them are really interesting, like Vinod showed us. I think the first, information about a lot of them, I think even the thalidomide was a case report itself. So many of them have come across. So they are really important for the body of literature that we have. Vinod, do you want to say a little bit about case series? And sir, where do case series fit in, sir? Case reports or in parent IJO?
Depending on the number of cases, anything less than 9 is considered a case series. So it goes into case reports.
Okay.
Yeah, most of the journals say 10 and more can become an original article. But one thing I've noticed over a period of time, especially in today's scenario, it's much more difficult to publish a case report or a case series. If your study has been well done, there are much more journals which are ready to take original articles and the reviews, but it's very difficult to publish, especially in good journals, the case reports and the case series.
If no more questions, I think we can go to the next talk. Thanks a lot, Vinod. Very well elucidated, and fantastic presentation as usual. Thank you so much.
Thank you.
Next, we'll go over to Dr. Jyotirmay Biswas, fondly called as Dr. JB. He's going to be talking to us on how to write an original article, and just after the case report, I think the next important one would be the original article. As Sir pulls up his slides, let me just tell you briefly about him. He's specialized in uveitis and ocular pathology. He's done a fellowship in VR surgery, though first from Shankar Nethralaya, and a fellowship in ocular pathology from Doheny Eye Institute in the US. He has close to 500 articles in PubMed and 62 chapters in books, and he has presented over 300 papers in national and international conferences and several books on both uveitis and ocular pathology. He's a visiting professor at AAC PGI in Chandigarh and the Chinese University of Hong Kong. He's a member of the International Uveitis Study Group, the American Uveitis Society, and the International Ocular Inflammation Society. He's also the founding member and the past president of the Uveitis Society of India. And he was the first to describe ocular lesions in AIDS in India, which is why he's the best person to tell us about how to go about writing an original paper. Over to you, sir, and thank you so much for consenting to do this.
Thank you, Dr. Chaitra. Thank you, Dr. Santosh, for inviting me to share my thoughts on how to write an original paper. I feel considered it is a great honor for me to share my thoughts to writing an original paper. I will be, some of the things as repeated. I'll talk about that few pearls or few salient points. The man of science appears to be the only person who has something to say just now, and the only man who doesn't know how to say it. Many of us ophthalmologists are often like this. They have got something to say and they don't know how to do it. It is very important that we only do science, but must write science. So I'll be sharing in this small span of 13 to 14 minutes, practical pearls. What I do is, my first 5 commandments is that I ask, is the work publishable? And if it's so, then I ask myself, who would be my target readers, national, international, ophthalmologists, all medical personnel. And then choose the journal, it is the most appropriate journal. Always, of course, you should try to do the higher ranked journal with good impact factor. What is the priority of the work? If there is several papers or publications pending with that one, where I put this, my work, and what's the time frame I can handle, and I make it a small kind of a time frame for each of the article. So coming back to the very different component of the original paper, the title is the most important. As you say that the first impression, the strong impression. A title ought therefore to be well studied and to give, as far as limit permits, a definite and concise indication of what is to come. I write a few titles first and then choose the one which best conveys the contents of the paper, and finally decide the title. For example, I wrote a simple title, Ocular Tuberculosis in Acquired Immunodeficiency Syndrome, in Ophthalmology Journal. This article, there is not much of work done in ocular tuberculosis in AIDS that time. So this simple article title worked well. And this is another article where I use the term, the quite elaborate one, a clinical histopathologic and electron microscopic study of pneumocystis carinii choroiditis, which describes what is exactly the contents of the paper. So the title may be a small or large, depending on the type of the work which you have done. The title page, I am not going into the details of it. It should have that format of full title, abbreviated title, author's names, and all these things. Next is the very important component of the paper is the abstract. Abstract is come in the literature search, in the PubMed, or any of the electronic literature search. It should be the mini version of the paper. It is the roadmap for the paper, and each journal has got word limits for the abstract. It can be structured or unstructured. Mostly it's structured, and when it's structured, it says a purpose, methods, results, and conclusions. I particularly concentrate on the results, and as much information I try to put in the results so that the readers know that what has been found in the original study, and should be written in the past tense, obviously. This is an abstract which I have written for ocular lesions in AIDS in India. I am not able to read out. This is very small print. Next, coming to that body of the paper, which is the introduction, material, methods, results, and discussion, which Shabashati has told about it. What is the IMRAD, what you call IMRAD format, the time-tested format of that original book. IMRAD format is the introduction, means what is the problem, and second is the materials and methods, how did I solve the problem. Results is the what did I find out, and discussion, what does it mean. There should be 5 or 6 keywords which should be well chosen, because the article could be found out by the literature search with that keywords. So you should not really ignore this part of it. Next comes the introduction. It's a bad beginning makes a bad ending. So introduction is a funnel approach. First, you define the problem, then a brief review of the work done in the related field, your approach to the problem, hint at the publication results which you have, principal results which you have achieved, and then the what you have got to say in the paper. For example, I just want to read out this one. Here, where background cases rates of TB are among the highest in the country. Highest in the country. And then I enumerate that ocular TB can present with the protein manifestations, including choroiditis, choroidal granuloma, chorioretinitis, endophthalmitis, subretinal abscess, and panophthalmitis. And each of them I quote the references. And there are only few reports of ocular TB in AIDS patients in the literature. And then we say that what we have done, we describe the clinical profile, histopathologic and microbiological correlation of ocular TB in patients with AIDS from a tertiary ophthalmic care center in India. It should be about 10 to maximum 10 to 15% of the paper. Next comes to the material methods, and it should be written properly. The relatively easier to write. I often write it before that paper, other part of the paper. Paper can also get rejected, mainly due to the ambiguity in this section. So be careful about the materials and methods. Give relevant details so that a competent worker can reproduce. It's like a recipe you are giving it, following follow the chronology of the events. Use proper statistics to support your conclusion. What statistical methods which you have used. You should consult a biostatistician while planning the project rather than at the end, and because then my results will not be really able to validate or analyze properly. So this is a 33% of the mice got cured, 33% of the mouse are unaffected, and third mouse got it. That's not the statistics. Statistics should be quite relevant, and nowadays it's often beyond the scope of this talk to talk about what statistical methods which you use for the paper, but this should be enumerated in the. This should be stated at the material methods, that what statistical method has been used, what software has been used for that purpose. Results is the most important part. This is the core of the paper. Select the representative data, clinical or basic science, whatever you are going to do it. Use tables, graphs, and photos judiciously. Don't compromise on the quality of the photographs. And the paper can get selected if you have got a good photograph depicting your results. Results should be short and sweet without verbose. Results should be presented in the past tense. So table and graphs are quite important. A tabular presentation of the data is often the heart, or better, the brain of a scientific paper. For example, I described that clinical characteristics of cases of ocular tuberculosis in AIDS patients described in the literature. So name and country, year, cases, case presentations type, there's diagnosis, extraocular features, and the outcome. And then make it put on a table and see that where our study fits with. Then one can use the graphs very elegantly to show the visual improvement by a scatter diagram. Or next comes the discussion. I feel it's the most difficult section to write. Don't beat around the bush, be focused, be crisp, clear, and to the point. Discuss your major findings first. You should not repeat the results in the discussion. Tell how the results and interpretation agree or disagree with the earlier works, and put references for the same. Tell theoretical and practical implication of your study. tell limitations of your study, and then tell the strengths of your study, and end with a short and sure message. It's a kind of an inverted funnel approach. You come down to a conclusion, and the conclusion should be like finally good writing had a good music, a fitting climax. So about 3 or 4 sentences, you should find out what you got and what's the implication of your study. So now comes the references. It has been already told elegantly. There are a lot of tool is available for writing the references, but I just like to mention this, that it should be limited. Non-manuscript containing innumerable references are more likely a sign of insecurity than a mark of scholarship. So list significant published references. You do not need to annotate all the references unless you are writing a major review. Just take that leading reference and then recent references. Unpublished references should be cited only if absolutely necessary. All the references should be complete with author name, years, article title, journal name, volume, page extent, publisher, and should mention the text citation. You should be very careful. You put the references over there and that's not mentioned in the text, should not be there. So there is the alphabet number system, which is Survey of Ophthalmology uses it. Most of the one Vancouver style. References, if we access the website, you should write the access date and where is the website from where you have taken. Next is the figures and legends. It's very important. I look into this carefully. The legends should be such, figures should be well chosen, and legends should be written in such a way that it stand alone, and the reader can understand what is the finding of the case through going to the legend itself, and don't need to go to the text for that description of the figure. If you use the micro photograph, don't forget to use the stain used and the magnification which has been provided. Put arrows and bullets, put arrow asterisks to highlight the certain part of that one. This is also important to crop and label. As I mentioned to you, some of the things like particularly micro photograph or is some of the areas which is the artifacts comes or some of the things which you don't want to highlight, you can be crop it and make it very elegant. Style, grammar, and syntax now is automatic available. The corrections is not really, but be careful about the grammar, style, and syntax. Spelling mistakes irritates the reviewer. Do not use double negative. Do not use the present tense for one's own work. Do a spell check. Avoid the repetition of the words. Avoid the complex sentences. So, for example, use the words in proper phrase, like I hit him in the eye yesterday. Only I hit him in the eye yesterday. Uses of the word at the place makes it a lot of difference. So, choose the words carefully. And finally, acknowledge the person's significant help or technical help or funding at the end of the manuscript. If you have got a significant help from the English writer, editor, mention it here. And finally, go over it critically several times. Review after a break. Give it to your colleagues for comments. I even give it to my fellows, juniors to have a look. How does it sound? And don't discard the previous draft's paper even after the publication, because you might get a rebuttal, you might get a letter to the editor which you need to answer. So keep that data in carefully, and that's all which I have to say. So I wrote in long back, 1998, Indian Journal of Ophthalmology, practical suggestions for the writing of a research paper, which might be still valid now. And with this, I end. Thank you once again.
Thank you so much, sir. I think you've gone into all the details that one needs to be equipped enough to start writing an original article. Does any of the panel have questions? I think sir mentioned something about grammar, and now there are a lot of these tools available online called Grammarly. But I don't know whether that really is helpful for scientific writing. But overall, I think it's one thing, because unfortunately, a lot of the Western journals, outside of India, the minute they know where the author is from, they do tend to be overly critical, I feel. Even though our English is fairly good, most of us write fairly well, the comment always comes says that get a colleague or get professional help. So I don't know whether that's really valid. I don't know whether Dr. Honavar has something to say about this. A lot of us, I think one paper that Anand and I recently worked on, the journal insisted that we get a certification by a professional editor on the language and the grammar. I don't think it's fair. So what do you think?
I don't think it's fair at all, because I think they should go by case to case basis rather than clumping all articles which are from non-native English speaking countries together. I think they do that stereotype manuscripts.
Even the English writer corrects it. You need to see it again, because what happens is that they change it such a way the scientific content gets altered. So the English sometimes is that, like, they put some of the words which make the meaning different. So even an English writer corrects it. You need to see it again. That's what I think.
So thank you so much, sir, for your talk. We'll go over to the last and the very sensitive talk on ethics and when we should not be crossing the Lakshman Rekha. I request Dr. Honavar to start sharing his slides and a quick introduction about him. All of us know him very well. He's the current editor of the Indian Journal of Ophthalmology, and he's doing a fantastic job of improving our impact factor, turnaround times, and generally the whole the quality of the journal has improved so much more. And he's also started both the case reports of IJO and also video journal, which I think is the first that is already indexed, because I think that's fantastic. No other journal so far has. He's the director of medical services for CFS, and also the director of the Department of Ocular Oncology and Plasty at the Hyderabad Center, and the director of the National Retinoblastoma Foundation. So as far as his publication journey goes, he's published several papers, and I think when I last checked, to speak about him, he has, I think, crossed 300. Besides his publication journey, he's also written a lot of books. He's contributed immensely to the whole literature about retinoblastoma itself and ocular pathology lesions. So over to you, sir, on publication ethics, please.
Thank you, Jaitra. Thank you for the initiative. I think it is a wonderful collaboration between KOS. I think this is your first meeting as the Chairman Scientific Committee of KOS, and you are very much interested in editorial process of IJO, part of IJO. So I think it's a very good synergy. So I'll be talking about publication ethics, which is somewhat ignored part of publication process. I would try to insist that it is not a transient line on sand ethics, but it's an indelible Lakshman Rekha which none of the authors should ever cross. Well, publication ethics does not involve just the authors. It also involves reviewers, publishers, and the editors as well. But for today, we are talking about publication ethics as relevant to authors. Research is solely based on trust, and trust, as you know, is hard to build and very easy to lose. Loss of trust has a cascading effect, not just on the author's reputation, but also on the reputation of the organization which the author is working for, and unfortunately, even the co-authors. So if one author has treated ethics without the seriousness that it deserves, then it can reflect on the reputation of co-authors as well, and the department and the institute. It's very difficult in academic world for the trust to be earned back. Being an author or a co-author on a research paper involves taking responsibility for all this: originality of the publication, fact that there is no data fabrication or misinterpretation, wrong statistical analysis, wrong interpretation of data, data or image manipulation, plagiarism, and appropriateness of authorship. Ethics approval is considered mandatory for all scientific publications. You might say that I just have a case report or a small case series. Would I need ethical approval? Well, many of the journals now insist on ethics approval even for retrospective studies and for case reports. It could be your institutional ethics committee if you have a larger institute, or if you're part of a medical college or an organization which has ethics committee of its own. Otherwise, you can go for an independent ethics committee in your geographic location. There is, in India at least, there is this geographic location limitation. I think it's 40 kilometers from the place of work. So you have to actually get it approved by an independent ethics committee, which may require some nominal payment. And all the ethics committees currently, at least by the Government of India regulations, should be accredited ethics committee. If your ethics committee is not accredited by the Central Drug Standards Control Organization, then your ethics approval is not valid. Especially when this approval needs to be produced on demand by the journal, and if it's not an accredited ethics committee, then your article may be liable to rejection. Not in IJO, but many of the reputed journals now ask for ethics approval as part of the review process, even for case reports. So this is mandatory now. All clinical trials must be registered. Prospective clinical trials must be registered. This is mandatory for almost 13 years now. 2009 June was when it was made mandatory. For any trial involving human participants of any intervention, including drugs, surgery, preventive measures, lifestyle modification, trial of a new device, even surveys, which look at sociological behavior or life or quality of life issues, rehabilitation strategies, and including PG thesis. So this is something that is very important. And the process of registration may be sometimes time consuming. So it's very important that we do it right in the beginning. Even before we recruit our first patient, studies need to be registered. Informed consent is mandatory for all study participants. There's an ICMR template for informed consent for study participants, which may not be relevant for case reports and short case series, but for prospective studies, yes, this template is supposed to be used. It is advisable to obtain blanket consent for use of data and images from all the patients at the point of entry. That's what we do, and majority of institutions do that. When the patient is checked in for the first time, a consent is taken from the patient for possible use of data and the images. And if the patient's face or recognizable part of the body is to be used, then you have to take special consent as well. Now, what about data ethics? Data ethics, there are many aspects to it, one of which is fabrication, drawing conclusion from data that is not generated by the study. Ballooning is fabricating higher numbers than real. For example, if you have 100 patients and you want to make it 500, then that is data ballooning. Falsification is manipulating research materials, processes, or changing or omitting data. So you may even omit data that is kind of casting a negative shadow on your results, or you may add more data that is not part of your results. So, or misrepresenting data that may not be part of your results. So in such situation, if there is a suspicion that the data is either fabricated, ballooned, or falsified, journals may summon raw data even after publication. Or if there is a anonymous or a named complaint, then the journals are bound to summon raw data. And if that is not tallying with what has been used in the publication, then there might be punitive measures that may be taken. So it is a good idea, if you've done a good study, secured the data set, including patient tracing information. Sometimes patient medical records may not be traced after a while. So it's a good idea to have tracing information available as part of your data set, including medical record number and patient's mobile number, email ID. Even though anonymized, name may be anonymized, but all this information should be available as part of your data set. Plagiarism, kidnapper is the kind of translation for the word plagiarious, and it's the use of previously published work by another author without consent, credit, or acknowledgement, and fraudulently passing it as one's own work. In fact, it is considered the most common form of publication misconduct. Now, what are the types of plagiarism? Complete plagiarism is when you take somebody's work and publish it as it is, just changing the name of the authors. This has been found happening, not very rare. People pick up material from obscure journals and present it to another obscure journal without changing a single word, just changing the authorship. Direct plagiarism is when you take out parts of the published work, paragraphs or sentences, and directly copy and paste onto your manuscript. Paraphrasing is when you change part of the sentence without changing much of the idea or the thought process, but change only part of the sentence and use that material. Mosaic or patchwork or potluck plagiarism, when you take bits and pieces from different work and present it as your own. Self-plagiarism is when you use your own previously published work without changing much. In fact, if you want to kind of republish something with 60 or 70% of your old work without changing much of information, that becomes self-plagiarism. Source misrepresentation is when you've taken others' work, but you have misrepresented or miscited the source, or you have hidden the source. Accidental, when you don't realize that you're doing it, but actually it happens because you may have read a particular work several times that you may try to use a kind of similar idea or similar sentence formation in your own work without citing it. So how to avoid this particular mistake is try to be original as possible in your writing. Summarize all the available knowledge in your own words. Paraphrase line by line without kind of using previous author's work. Wherever it is used, even if you're summarized or paraphrased, you have to use appropriate reference and citation. And if you have directly reproduced a definition or diagnostic criteria or anything for that matter, a few sentences from a previously published work, it has to be in quotation marks. So if you don't do that, then it is considered plagiarism. So you have to make sure that whatever that is directly reproduced from previously published work, even if it is a definition or diagnostic criteria, that should be within quotation marks. And always use a plagiarism check software to avoid accidental use. Sometimes it's possible that you may have used a few sentences from previously published work, or it may sound similar. It may be paraphrased similarly. So you should always use a software. Some of the softwares are freely available. Some your institution may have bought. Authenticate is something that most of the journals use. So if you use the same, then the chance of getting the percentage of plagiarism check similar would be much better. Grammarly also has a plagiarism check, PaperRater, DupliChecker. There are many other software which are paid or free that can be used. Now, duplicate submission is also considered unacceptable. If you have submitted to one journal, then you should not submit it to another journal until you get a very clear rejection. Duplication of publication of similar material is also considered unacceptable. Conference presentation and publication of the abstract in proceedings of the conference is, however, acceptable. There are two other terms that you need to know. One is salami slicing, that is dividing the results of your study into two or more publications without much change. Basically, you're trying to aim at more publications using the same data set, whereas BFUP is when you combine two data sets to enhance the chance of acceptance. These two are also considered unethical. Now, authorship, there are specific criteria. All persons designated authors should qualify for an authorship, and all those who qualify should be included. That means that you should not leave out somebody who is qualified to be an author just because you have a prejudice, or you have included somebody who is not fit to be an author. Both are considered unethical. Now, these are the authorship criteria: substantial contribution to the conduct of the study, including conception and design, data acquisition, statistical analysis, and interpretation. The author could have drafted the manuscript or revised the article for intellectual content should receive approval of the final version, and extent of contribution decides the order of authors. These are to be avoided. Ghost author is somebody who has written the manuscript for you and you haven't acknowledged it. But if you take the help of a publication agency to write the manuscript, then that some of the journals don't consider as ghost authorship. But if you very clearly declare that a writing agency has been hired to write the manuscript because you have language deficiency. Gift authorship is when you make somebody an author just because he or she is the head of the department or head of the institute without that person having done anything for the study. Guest author is somebody that is included because of the reputation, because of whose reputation your manuscript has a higher chance of being accepted. So ghost authorship, gift authorship, and guest authorship are something that are unethical. Now, what are conflicts of interest? Having a conflict of interest is acceptable. Everybody has some form of intellectual or commercial conflict of interest that is acceptable, but failure to disclose that conflict of interest is considered unethical. There could be direct financial conflict that derives from employment, owning stocks, patent of the product, or anything that does with direct financial gain arising out of anything that is used in that particular study. Indirect financial gain is when the author receives honoraria or research grants to do the study, paid lectures to popularize that particular product, career or intellectual or personal belief conflict of interest, or institutional conflict of interest. All these are considered conflict of interest, and it is always a good idea to declare all of these at the time of submission of the manuscript. Self-citations are also considered unethical. Unreasonable citations of one's own prior publications, which may not be very relevant to the study that is being currently published. This is done by many authors to increase their own citation index or H index, but it is picked up as an index of academic dishonesty by many of the indicators. There are, apart from these defined dishonest measures, there are questionable research practices such as selectively reporting dependent variables, collecting more data after the study is concluded to make the findings significant. That means you're selectively collecting certain amount of data after the study is concluded just to make the findings significant after having analyzed the data and realizing that your study is throwing up insignificant results. Reporting selective studies that have worked and suppressing part of the studies that has not worked, rounding p-value to make it significant, and reporting unexpected findings as having been predicted previously. Consequences for misconduct can be severe. Whenever the journal suspects or the reviewers suspect that there has been a misconduct, the authors are contacted, they are informed of the misconduct. If they accept it, then if the manuscript is not already accepted, then it is generally rejected. But if the manuscript is already published, then if it's a minor error, then a journal insists on publishing an erratum. If the error is major, then sometimes revoking the manuscript, then inform member journals basically to blacklist the author and inform the institution to which the author belongs and also to the ethics committee. Institutional discipline measures include demotion, punitive measures including termination. All these have happened in the past and authors should be aware of it. This lecture is based on one of our publications in Indian Journal of Ophthalmology, which has a checklist to detect if your particular manuscript has any of these dishonest measures. Thank you so much.
Thank you, sir. I think some very, very important points there. We tend to overlook them, but every single one of them is really important. And I think for beginners, the sooner we learn it, the better it is, because so many times, later in the day, we don't know how to handle it. And I think that's particularly true for people who've started writing, who have the tendency to copy entire paragraphs, because it's just so easy, right, to just put it all together. But then invariably they all have a software now that they can run and check, and unfortunately not always that similarity index is correct, because it picks up very silly similarities like a man aged so and so. It's so difficult. How do you change that? So really, there's no way to overcome that. But having said that, sir, thank you so much for all the important points that you put across. Anybody else on the panel would like to add anything more to what sir has said?
Can I ask a question to Dr.
Yes, please. Yes.
Sir, what is the policy regarding presentation of original work in conferences and publication? It is usually said that once it has been published, you cannot present in the conferences. Or if I've presented in one conference, can I present in another? Or for example, if I've presented in a national conference in India, can I present in an international one?
Each conference has its own guidelines, so we cannot generalize it. If it's for a competitive session, if you have won an award already for that particular work, some of the conferences will not like to give the same presentation and award again. So this is specific to each conference, but there is no rule that if you have presented it in a conference you cannot publish, and if you already published you cannot present. There are no generalized rules like that.
So there's one more question which Dr. Nikita has asked. If we did a randomized study thesis in 2020, but only later realized that CTRI was mandatory, and if we plan to publish the thesis paper now, how do we write it? Can we publish it as randomized?
Journal may not accept it at all because it's mandatory now that all prospective studies are CTRI registered. If it's not registered, journals may not publish it.
So if no more questions and no more inputs, we think we can call it a day. We've had an extremely good
Sunny
session.
was saying something, yeah.
Sorry, Sunny, go ahead, please.
Santosh sir was very clear about publication ethics the day he took over, and that's why that editorial was published with those checklists. So and then we definitely see a lot of lot of copycatting, if I want to call that. So that's not just plagiarism, but a lot of other things definitely do happen. So when you're on the other side of the chair, you get to realize that these are realities. So that is one. Like Vinod was saying, there are some conferences like ARVO where they actually publish some abstracts in their IOBS journal. So then once that is published in the journal, just the abstract, but that still comes as a PubMed indexed publication. So then it sort of looks like plagiarism or self plagiarism that it's already published. So but then there are very few conferences which do that. Lastly, I would sort of like to bring in that Committee of Publication Ethics, that is a COPE, which is a very large organization with a lot of large journals which and publishers which are part of that. And so they have a Facebook page where you can go and follow their work. They have newsletters once a month where they sort of publish interesting cases of misconduct, not just plagiarism, but a lot of misconduct and how it was handled and others. So so people are interested in knowing more about ethics. COPE is the best place to look.
Thanks, Sunny, for those points. So, and this is an source that is available online. So one can always go in and go and look for more of the details. So thanks everybody for taking time off on a Sunday evening. I know it's one day of the week where we doctors get a day off to spend with their family. But thanks for doing this, and thank you, sir, for this idea, because it's my first as a scientific committee chair, and I thought it's really symbolic to start off with IJO since we are a scientific community. And besides all the panelists and the speakers, I must thank the attendees again for listening to us and for even interacting with their doubts and questions, and to team KOS for the support and for the encouragement, and our president Dr. Patil is also logged in for the meeting. So thanks a lot to all the office bearers and the members of the scientific committee. Thanks everybody. Good evening and have a great week ahead.
Thank you, Chaitra.